for you so that you know what contains what. There are good figures in your textbook, and there's a good image for you to label right here if you don't remember where stuff is. But I'm going to start with the assumption that you remember the anatomy, okay? And so we are going to basically just start talking about renal functions, and really all of the interesting physiology in the kidney really happens at the nephron. And you remember our friend the nephron, right? This is the picture from your anatomy book. The nephron is the microscopic location where you have blood tubes next to P tubes, right? Basically capillaries next to what they call the renal tubule. Conceptually, please remember that you do not hook up the blood tubes and the P tubes, meaning that there is no direct flow between blood and P, right? What you do is stick them close enough together and make them porous enough that you get good exchange between them, right? So we are going to look at nephron function today, and you're going to have to remember the anatomy. So here's what you are going to do. The blood that is going into the renal artery should be different than the blood that's coming out of the renal vein, right? Because you are actually going to process what's going through, and primarily what you're going to be doing is processing the blood plasma. And by doing that, you are able to regulate the water concentration or the osmolarity that's in the blood plasma, right? Choosing how much to keep versus how much to pee out. And by doing that, you are, of course, directly going to impact the blood pressure. You guys with me? If you regulate water volume, you regulate blood pressure, okay? You are also going to do what most people have known that the kidneys do since they were kids, right? Most of the time before you get to college, you think of the kidneys as primarily getting rid of wastes. And that is a small part of what they do, but an important part. They get rid of urea and uric acid and ammonia and other nitrogenous waste products. So it definitely does do that. In addition, your kidneys decide how many ions to keep versus get rid of. Okay, so remember, for instance, that calcitonin, one of its functions, in addition to targeting the bone, it also targets the kidneys, right? Because it's supposed to tone down blood calcium, and it can, for instance, tell you to pee out more calcium. So you won't be at all surprised that your kidneys really get to decide how much of the ions that go through them make it back into your bloodstream and how much of them get peed out, right? So they are regulating all of those things. You are also getting rid of foreign chemicals like drugs and pesticides. Some of those you get rid of through your kidneys, and some of them you actually get rid of at your liver, and some both. And then there are some secondary kidney functions. These you may or may not know about. Your kidneys in a pinch remember how to do gluconeogenesis. It's primarily a liver function, but if you are starving, your kidneys will go, I'm not sure I've done this in a while, but I think I can do it. And they will do gluconeogenesis. In addition, your kidneys, you also know, make two hormones. Question for you. EPO. You make EPO in order to cause erythropoiesis. What's the trigger for EPO release? Low oxygen, exactly, at the kidney. Okay. What about renin? Renin, which ultimately causes the release of angiotensin II. You make that at the kidney too. Why do you release renin? Low blood pressure at the kidney, exactly. Okay, and then one last thing that the kidneys do that you may or may not know. The kidneys are actually important in activating a form of vitamin D3. So if you have kidney problems, you can have vitamin D problems. Okay, so primarily what the kidneys are going to do is a three-step processing of the blood plasma that will end up cleansing the blood plasma, keeping all the good stuff, hopefully getting rid of the bad stuff and the excesses. And the three phases are filtration, reabsorption, and secretion. And then whatever you leave in the renal tubule will get excreted. Okay, so we're going to go through those processes today. That's what we're going to spend most of the time doing. But before we do, I want to make sure that you guys have sort of a graphical understanding of what's going on with filtration, reabsorption, and secretion. Okay, so this is the same thing we're talking about right there. So basically what we have at the nephron is microscopic blood tubes next to microscopic P tubes, right? And they got a lot of surface area, and they're really thin, and they're really porous, so I have lots of room and time for exchange. So let's just simplify it a little bit so you can see where the blood tubes are next to the P tubes. It's highly curved, of course, but we're going to represent it more simply, right? We're just going to sort of stretch it out. And then I'm going to even represent it more simply than that. So I'm going to say basically you've got these tubes that are next to one another, okay? And one of them is going to contain blood, and the other one is going to contain what we call filtrate or urine. Not that it's particularly important, but it's actually called filtrate until it hits the collecting duct. And ultimately what the blood is going to do is it is going to come in ultimately from the renal artery, and it's going to go back out to the renal vein, right? And you're going to change its composition as it goes through there, otherwise why the hell bother, right? You're going to do something to it as it goes through there. And then the filtrate or urine is not circulating, correct? It doesn't go back through the body. It's a blind end. It like starts here and then it ends up in the toilet. That make sense? Okay, starts at the kidney, ends up in the toilet, okay? And then I've got all of these locations and I'm basically going to have this 3-step processing system. Okay, so the blood that goes into the kidney has not, let's say, been assessed. And so I like to use this metaphor when I'm talking about kidney function. I want to talk about what you do with the blood that goes through your kidneys as like cleaning out a house in hoarders, okay? So there's just so much crap in there that the first thing that you need to do in the process is take everything that will fit through the door and dump it out on the lawn. It's a really general process, and it's not really being selective except by size. That's why it has to fit through the door. So there's going to be a 3-step processing system, and the first one is going to be called filtration. Filtration is pressure driven. So if I tell you it's pressure driven, and you look at these two fluids, which of these fluids is going to be higher pressure? Which fluid? Yeah, blood is way higher pressure, right? It's got a heart hooked up to it, right? So you guys know filtration. You learned it in 1610. We talked about it again at the beginning of the semester. Filtration is pressure driven, and it's not selective. It pushes everything that'll fit through the holes. And so what are you going to filter out? It's really general. It's going to be boatloads of water, about 47 gallons per day at your kidneys. Also, anything else that will fit through the holes, like ions are small, right? They'll fit through the holes. Waste products like urea and uric acid, those are relatively small. They'll fit through the holes as well. Glucose and amino acids are small enough to fit through the holes. Now, I don't want to lose those, but this isn't selective, right? So when I'm cleaning out the house, I might end up with my grandmother's china out on the lawn with the 17 cat boxes out on the lawn. And maybe even a box of money that I forgot that I had, right? But I've got to dump it all out, and then I'm going to start pulling it back in. So this is all only selective by size. So let's think. In a normal, healthy person, do you think that you should end up with whole blood cells leaving here? No. Whole blood cells should stay. So they should not get filtered out. How about large proteins? No. Large proteins should stay as well. That makes sense? Okay. Now, if a person had chronic hypertension that was untreated, can you see how you might get big proteins and blood cells in your urine? Right? Because you can push anything through a membrane if you have enough force. Okay. So now, we haven't gotten the house cleaned yet. Basically, all we did was just basically generally take everything and dump it out on the lawn. Now the next step is going to be to assess what is out on the lawn critically and decide selectively what to bring back into the house.
Bring those lotto tickets back.
There's no reason to bring the cat box back in, right? How about grandma's china and a box of money, right? So you're going to bring that crap back in. So the next step is this. It's called reabsorption. Which direction should it move things? This direction. What should it move? Well, I need to reabsorb a whole bunch of water because the process of filtration filters out 47 gallons. You filter out more than 46 and a half. You reabsorb more than 46 and a half gallons. So I reabsorb a whole bunch of water. And what about glucose and amino acids? How many of those do I want to reabsorb? All of them if I can. Urea and uric acid. I don't reabsorb those unless I actually need them to regulate my pH. Most waste products I will leave out there. And ions, well, it really depends with my ions whether I reabsorb them. What if I was calcium deficient? Then I would reabsorb all of it, right? But if I had too much calcium, I can leave it out there. So this is where you can start being selective. So what I will say about ions is that I will reabsorb ions as needed. Does that make sense? Okay, so with the ions, I want to think about like a potentially helpful nutrient that you had in your house, but not money. Like you've got like, you were a hoarder, right? So they had cream corn on sale at Costco, and you bought 400 cans of cream corn. And you're like 85, you're only going to live 5 more years. You don't need 400 cans of cream corn, right? So you dump them out on the lawn, right? And you're like, okay, well, I understand that you need some cream corn, but I'm going to give you 20 cans of cream corn, all right? Cream corn is disgusting anyway. So you're going to bring 20 cans of cream corn, and you're going to leave the rest of it back out on the lawn. So you can select how much of those things to bring back in. Okay, and then the third stage is a selective looking through every cabinet under every bed in the house. This was not selective. This is just everything that you see dump out. This is selective. I'm going to look through every cabinet. I'm going to find another cat box under a bed, right? I'm going to find 25 more cans of corn that I didn't see the first time, right? And then I'm going to find trash heaps and locations and everything that I didn't catch. I am going to secrete. And what am I going to secrete? Mostly, this is an oversimplification, but mostly I will secrete wastes and excesses. That make sense? So I'm just going to carefully, so this is selective and this is selective, okay? And then what I'm going to do now is the last step is anything that got filtered out, didn't get reabsorbed or got secreted into, ends up getting in the toilet. And that part is called excretion. So you're going to pee whatever ends up in the tube out. So basically, excretion is filtration, right? Minus reabsorption plus secretion, that's what you excrete, okay? That's what you end up peeing out, okay? So what we're going to do is we're going to talk about each of these 3 processes. We're going to put them in an anatomical location in the kidney, and then we're going to talk about what you actually move, okay? And we are going to hook hormones to the functionality, because I know you like your hormones. I know you do. Okay, so we're going to be talking about some ANP, some ADH, some aldosterone. It'll be so fun. Okay, so first step that we need to talk about is filtration, which is pressure driven. I bet you won't be at all surprised that one of the great reasons to cover urinary system after cardiovascular system is we just spent a whole bunch of time talking about blood pressure, which will directly impact what's going on here, right? So we call this glomerular filtration, and so it is going to happen at this location. So remember that when you are looking at a nephron, you have the glomerulus and then Bowman's capsule, or the glomerular capsule. This contains blood, right? This potentially contains filtrate. Filtration is going to move from high pressure to low pressure, and filtration is super duper effective at these locations. I'll tell you why in just a second. So the site at which this occurs is called the filtration membrane. So let's look at like actually where it's going to occur. So here is what it looks like. This is afferent arteriole going in, efferent arteriole going out. This is the glomerulus, but it's also coated with the inner layer of Bowman's capsule. Okay, so you're seeing the reason it doesn't look like a capillary is because it's actually got a glove on of Bowman's capsule. So if you look at it more closely, you can see this inner layer is a really porous capillary, and the layer that's on the outside is Bowman's capsule. So the site of filtration is right here. So if you blow that up, here is the lumen of the capillary. Here is the Bowman's capsule space. And there's not even any connective tissue in between them. It's just a basement membrane, okay? So this site is called either the glomerular membrane or the filtration membrane. And it's really effective at filtration. It, collectively, you have 1 million nephrons per kidney, about, right? And collectively, those over the course of a day will filter out 47 gallons or about 180 liters of fluid, okay? The rest of the capillaries in your body combined filter out about 1 gallon a day. So why the hell are these things so good at filtration? Does anybody know? There's some anatomical tweaks. There's some interesting things that happen there. The reason they're so good at filtration is 3 things. First off, surface area, right? 1 million of them per kidney, right? So that's a lot of surface area. And then second, look how porous it is. Do you see how porous it is? It's fenestrated capillaries, and there's a whole bunch of holes and spaces, which allows for more filtration. And there's the other thing that this is this little anatomical tweak. I don't know if you looked at this in anatomy. Even though it's not really clear to see, do you see that the afferent arteriole has a larger diameter than the efferent arteriole? Do you remember that the afferent arteriole brings blood into the glomerulus and the efferent brings it out? Okay, so now imagine what happens to the pressure in 1,000,000 of these if in every single one the afferent arteriole is bigger than the efferent arteriole. What does it do to the pressure and therefore the filtration in the glomerulus? Yeah, it increases pressure and filtration, right? So those 3 little tweaks, right? Surface area, porosity, and increased pressure means that these are amazingly effective at filtration, okay? 47 gallons per day. So what we're going to do now is we are going to start talking about filtration, where it occurs, what gets moved, and why. So what we're going to be talking about is this concept called GFR, which is the glomerular filtration rate. And the glomerular filtration rate, so let's just look at the anatomy where this occurs. So I have 3 things that I'm going to be dealing with: filtration, reabsorption, and secretion. Okay, so where does filtration occur? It occurs from the glomerulus to where? To where? What anatomical structure? If you push it out of the glomerulus, it gets caught where? Yes, to Bowman's capsule, also called the glomerular capsule. So this is the pitcher and this is the catcher, right? Okay, so by the way, there is a name. I don't know why they thought you needed another name for things, but when you put the Bowman's capsule and the glomerulus together, they call this the renal corpuscle. So that's the site of filtration in the kidney, both the pitcher and the catcher. Okay, so the GFR is really impressive. The amount of water in here is probably about 125 milliliters, but that is per minute. 125 milliliters per minute. That's how much is filtered out. I want to talk about how you can impact GFR. So how you can change GFR. Well, actually, let me do this part first. As far as body-wide impacting GFR, does it surprise you that anything that impacts blood pressure could potentially impact GFR? Right? And we know how you impact blood pressure, right? You do cardiac output, blood volume, and vasoconstriction and vasodilation. So you probably won't be at all surprised that any of those has the potential to impact GFR, right? Okay, but now let's talk about how the kidney sort of tries to take care of itself, because there are intrinsic mechanisms that regulate GFR and there are extrinsic regulations that regulate GFR. The intrinsic ones, remember, won't involve nervous system and they won't involve hormones, right? They're generally just going to involve paracrine agents and they're not going to be as powerful, but they do have the ability to make little changes. So let's talk about that. Okay, so the factors affecting GFR. One of them is called myogenic regulation. And let me tell you what the job of myogenic regulation is, and then you can kind of understand why it works the way that it does. So if I get up and walk to my car, my blood pressure increases a little bit, right? And then if I lay down, my blood pressure decreases a little bit. Do you think that I really want my GFR to change every time I change body position? I might want my GFR to be relatively constant despite slight changes in activity or positional changes. Does that make sense? So how can you manage that? Well, what happens is we have this little myogenic regulation that occurs at the juxtaglomerular apparatus. Do you remember the juxtaglomerular apparatus? Okay, so this is not hormones. This is just a local thing. So what happens is if you detect an increase in systemic blood pressure, then what happens is if I want to keep my GFR constant, I'm going to tell you that I'm going to change the diameter of my afferent arteriole. I'm going to let you guys tell me whether I constrict it or dilate it. So I just got up to go to my car and my systemic blood pressure increased. Yes? But I want my GFR to stay constant. What do I do to my afferent arteriole? Constrict it. Yes? Okay? If I dilate it, all of that pressure is going to go into the glomerulus, right? Now I'm going to lay down. I'm going to take a nap. I remember one time I had a nap in my life. It was nice. So I'm going to lay down and take a nap, but I still want to cleanse my blood, right? So my blood pressure is going to drop, but I want my GFR to stay constant. So again, I'm going to impact my afferent arteriole. What should I do to it? Dilate it. Got it? Okay. Now, this is just minor and it's paracrine. It can't take care of big pressure changes. Like if you go into circulatory system shock, this can't do crap, right? If your blood pressure is so high it's about to blow, it's not going to help you. These are for minor changes in position, right? And they have limited capacity to manage what's going on with the kidney. So that's called myogenic regulation right there. And then there is this other one, which is also kind of weird. So this one, see if you guys can figure this one out. So this is the distal convoluted tubule, right? And you guys, do you remember the distal convoluted tubule is when you're almost done with urine production. You're about to dump it into the collecting duct. Everybody with me? Okay. The distal convoluted tubule can talk to the afferent arteriole as well. And when the distal convoluted tubule has a whole bunch of filtrate/urine in it, it can say, whoa, Nellie, we got plenty of pee. Let's stop producing pee for a second. And it's going to tell the afferent arteriole what? Constrict or dilate? Constrict, exactly. This is called, big long word that means exactly what it says, tubuloglomerular feedback, right? It's the tube saying, settle up, wait up just a minute, I've got plenty of pee, okay? So it's the tube talking to the afferent arteriole. Good? So that's called tubuloglomerular feedback. Again, that's just paracrine. It's not massively effective. It can just do little changes. Okay. So these two are intrinsic regulation, just paracrine agents. And now let's talk about the extrinsic regulation. The extrinsic regulation is pretty much what you would expect it to be. Remember, extrinsic uses nervous and endocrine system, right? Anything that increases blood pressure tends to increase GFR. Anything that decreases blood pressure tends to decrease GFR. And that's going to be true with one little exception. And this little exception makes sense if you think about it evolutionarily. So one of the things that dependably increases your blood pressure is mild sympathetic activity, right? Like a little bit of sympathetic nervous system stimulation because it increases cardiac output and vasoconstriction. But I want you to think about sympathetic activity and kidney function. So now I am sprinting across the savannah trying to get away from a lion, right? And my blood pressure goes up because it does, right? We know the reasons that it does. Do I really want to increase filtration when I'm trying to get away from a lion? I do not. So does it make sense to you that although it's counterintuitive, mild sympathetic stimulation, in addition to increasing systemic blood pressure, also constricts the afferent and the efferent arteriole? And it's like, you got time to make pee later. You're about to die, right? So what happens is you do not pee as frequently as you imagine when you have your sympathetic nervous system turned on. It doesn't mean you're not going to pee immediately after, right? So what happens is with mild sympathetic nervous system activity, it causes constriction of the afferent and the efferent arteriole. And your GFR actually decreases slightly with sympathetic activity. It's counterintuitive unless you think about its functionality. And then it's like, yeah, that makes sense. That makes sense. Like, we got stuff to deal with. We don't have time to produce urine or energy to produce urine. So that's really the only thing that's counterintuitive is how the sympathetic nervous system affects it. So let's go back to shock for a second. So remember when we said circulatory system shock is when, is when the pressure falls so low that you are not delivering adequate blood flow to capillary beds. Usually that's about a mean arterial pressure of 45 millimeters of mercury or lower. And just so you know, these little tweaks right here can't do anything about that kind of pressure. They're like, you have no pressure, so I can't really do very much to work with it. So if your mean arterial pressure falls below about 45 millimeters of mercury, you don't dump out anything onto the lawn. You don't do filtration. And if you don't do filtration, you have nothing to reabsorb from. So pretty much what it does is pressure that low will shut down your kidneys. And that's called renal suppression. And when renal suppression occurs, very quickly you will stop with urine production, right? So renal suppression that results in anuria. So have you ever wondered why when you're in the hospital and they've given you a whole bunch of drugs for whatever, they make you measure your urine volume? Because they gave you something that potentially impacted your kidney functions. Now, if I want to know that your kidneys are working, a good indication is that you are actually producing urine. Okay? So what do they do if I have a person who goes into shock but also has kidney damage? So I want to give you epi, right, to bring you out of shock, but now I know that epi also causes potential renal suppression by shutting down the afferent and the efferent arteriole. So you don't want to give them epi. What they do is they give them dopamine, which is a mild vasoconstrictor that doesn't have any receptors on the afferent and the efferent arteriole, right? So it's nowhere near as effective as epi, but it's not going to shut down your kidneys. Does that make sense? So they give dopamine for that reason. Good? Okay. So that is GFR, and we saw the locations that it occurs, and now we're going to do the hard part. The hard part is tubular reabsorption. Okay, so we called it glomerular filtration, and then we have tubular reabsorption and tubular secretion. So let's put it back with the anatomy. So now what I have done is, oh, there's Zach Nephron. Isn't he cute? So now what I've done at the Nephron, what I've done at the Nephron is, nerd, what I have done at the Nephron is I've dumped a whole bunch of stuff into the Bowman's capsule, and then it's going to go through the proximal convoluted tubule, the loop, and then the distal convoluted tubule. Okay, so I have opportunities for reabsorption wherever I've got my blood tubes next to my P tubes, so I can do reabsorption and secretion. So what I'm going to do is I'm going to tell you the primary spaces that you do reabsorption, and then we'll talk about where you do secretion. So I reabsorb from the tube back into the bloodstream, right? Okay, but what anatomical structures am I talking about? I'm talking about primarily PCT, which is proximal convoluted tubule. Yes? And the distal convoluted tubule, and some other structures too, but we'll simplify it, back into the peritubular capillaries. Does that make sense? That's where it should go, right? So the proximal and the distal convoluted tubule, I'm pulling stuff back out of it and putting it back into the capillaries here. Okay? All right, so reabsorption is selective. It's specific. And now I'm going to put this back together with phys and some anatomy. Do you remember way back at the beginning of anatomy when you were doing histology that you loved so very much? Sure. That it all comes back together. That we told you that kidney tubules were made of simple cuboidal epithelium. Do you remember at all? Okay. So they kind of looked like this, simple cuboidal epithelium. So now what I'm going to tell you is reabsorption is selective because these guys have carriers and channels on them that bind to specific things to decide what to transport back in. That's why it's selective. So these guys are going to select what moves back in. Does that make sense? So these cells have carriers for instance, glucose on them. They've got pumps for sodium on them, for instance. So that's why you can select, because they actually are selecting what binds to them and what moves it back in, okay? So this is basically selective reabsorption. Okay, so the primary place that this is going to go on at the PCT and then some at the DCT. So let's talk about what reabsorption does. Reabsorption is moving substances from what fluid back to what fluid? Fluids.
Urine back to blood.
Urine back to blood, exactly. And so the normal GFR in liters is about 180 liters per day. That is a boatload. But you reabsorb usually 178 to 179 of those liters. So reabsorption is almost as active as filtration. And look what percentage you usually reabsorb of these particular things. I'm not going to hold you responsible for this table, but I just want you to look at the trend. So with water, you reabsorb about 99.2% of the water that you lose. With glucose, if you can, you reabsorb 100% of it, right? Urea, you only reabsorb 50% of it. It helps to maintain your blood pH. And with most of these, it's above 99%, above 98%, with the exception of potassium. Potassium's a weird one. I'll tell you why that one's so low as we get into today. So your reabsorption is incredibly important. And so what's going to happen is those cells are going to determine what moves things across. And it's going to be a process that we already studied, transepithelial transport, in which you take something from the apicals, from the lumen, move it across the apical surface, right? Then move it across the basal surface and then let it diffuse into the blood plasma. Remember transepithelial transport? And we are going to use the predictors that we learned at the beginning of the semester. How do you move something? The cheapest, fastest way you can. If you can get it via diffusion, you'll do that. If it's valuable and you can't get it via diffusion, you'll pay for it. You would do secondary active transport before you did primary active transport, right? And then with water, you don't usually have to worry about moving water if you move enough solutes because it will follow via osmosis, right? So that's the story that we're going to tell here. We're going to basically put together the story that we told at the beginning of the semester with this particular instance of moving things across. Okay, so we're going to talk about reabsorption of not everything, because you don't have that kind of time, and neither do I, but some important things. Glucose reabsorption, that's pretty damn important. Sodium, potassium reabsorption, and water reabsorption. Those are going to be the 4 that you're responsible for. Okay, so luckily, glucose reabsorption you already know, because all it is putting a specific instance of something you learned into the context of the kidneys. Okay, so I pushed it out via filtration, and now I need to bring it back. And I'm going to bring it back despite how much is in the bloodstream. So even if I had glucose in the bloodstream, I still want glucose because glucose is like money, right? So you want glucose back in, and you don't want to care about the concentration gradient. So what transport mechanism are you going to use? You're going to use secondary active transport because it might be going against its concentration gradient, but I still want it as cheap as I can get it. So I do secondary active transport with sodium, and then a carrier across the other side, and then I'm going to have to use the sodium-potassium pump to regulate the concentration. That make sense? So this is exactly what you learned before, but it's just putting it into the kidney. That's all, right? Does everybody see why you couldn't diffuse it, for instance? Because the bloodstream still has glucose in it, right? Okay, all right. So the problem is simply this. This is a carrier, and remember, carriers are subject to saturation. If they get full, they're full, and you can't transport anymore. So if it got full and I couldn't do any reabsorption, then what happens is I end up dumping it into the distal convoluted tubule and ultimately the collecting duct. And as it's moving its way through the distal convoluted tubule and the collecting duct, because I couldn't reabsorb it because of the saturation of my carriers, what happens to water as it moves through the tube? As the glucose concentration is really high and it's moving all the way through this tube into the collecting duct, what happens? You got it? What? No, not glucose doesn't build up. It's just in the tube. Yes, it brings water in because it's a non-penetrating solute. So remember how we have talked before about how, for instance, type 1 diabetes, one of the first indications that you have type 1 diabetes is that you pee like a racehorse, right? Can you see why? What you just did is you filtered out boatloads of glucose, right? Because you have tons in your bloodstream. You reabsorbed all you could, but you hit saturation. And so then you sent the rest of that glucose through the tube. And as if you've got this non-penetrating solute going through the tube, it sucks fluid into the tube, right? And then can you now also see not only why you pee like a racehorse when you're diabetic, untreated, but also why you tend to be very dehydrated? Can you see why? Okay, so it's all related to the same story. You can have a minor little instance of this after Halloween, right? You eat a whole bunch of sugar, gets into your bloodstream, gets filtered out, and you just can't reabsorb all of it, and then you pee a whole bunch, okay? But that's not diabetes because it's only happening like at a single instance. So the excess sugar that remained in your urine in a diabetic situation is called glycosuria, and then as it exerts the osmotic pressure as it goes through the tube, it will cause polyuria. So if you have an untreated diabetic, they are going to have sweet pea, glycosuria, and lots of it, polyuria. Good? Okay. So how do you reabsorb amino acids and other nutrients? They have a similar reabsorption mechanism to glucose. Okay. So there are glucose sodium transport mechanisms. There are also amino acid sodium transport mechanisms. You don't have to memorize those. They're just like glucose. Okay, so we just did glucose reabsorption. On a good day, you will reabsorb 100% of the glucose that you filter out. Okay? Can't always, but on a good day you will. So this is where it gets sticky, and this is where you have to put it back together with the hormones that you learned, and you can do this, okay? So now I want to talk about sodium reabsorption. With sodium reabsorption, I do it twice. I push it all out via filtration, and then I reabsorb it once at the proximal convoluted tubule, and then again, if necessary, at the distal convoluted tubule. You guys with me? Okay, so I'm going to reabsorb from the tube back into the bloodstream. So I don't have any control over how much of it I push out, so there always will be sodium out on the lawn. And then sodium is going to be actively reabsorbed via carrier proteins back into the bloodstream. You have to pay to reabsorb sodium. Most of it, about 65%, will be reabsorbed at the proximal convoluted tubule back into the peritubular capillaries. This is what we call non-regulated reabsorption of sodium, meaning you have no control over it, hormones have no control over it, nervous system has no control over it. You are always going to do 65% reabsorption at the PCT. So they used to call it, they call it non-regulated, but they used to call it obligatory reabsorption. Do you know the word obligatory? It means that you have to do something, right? So you pushed it out and you're always going to bring 65% of it back into the house, and you have no control over that. Okay, that's PCT, non-regulated reabsorption. What you do have control over is that last 35%. You can decide how much of that to bring back in. So let's just think about reasons in which you might want to bring that 35% back in. What if I had low sodium in my bloodstream? Then I want to reabsorb it. What if I had low blood pressure? Then I'd want to reabsorb it, right? What if I had low water? Then I want to reabsorb it because it would bring water in it with it, right? So there are reasons that you might want to reabsorb some or all of that 35%. You guys with me? Okay, so some sodium is reabsorbed in the distal convoluted tubule. That is primarily hormonally controlled. Sodium reabsorption in DCT varies depending on the body's needs and the hormones that it releases. So what happens in the DCT is called regulated reabsorption. What happens in the PCT is called non-regulated reabsorption. I can reabsorb 0, 35%, or somewhere in between in the distal convoluted tubule. So let's put together two hormones that you already learned. It's the same story. It's just sort of knitting the story together. So ANP, our friend ANP, is released from where? The heart. In response to what? Why do you release it? No, what causes it to be released? Yeah, prolonged atrial stretching, which could be an indication of what about your blood pressure? Too high. Okay, so I'm going to release it in response to prolonged atrial stretching. And what it's going to do is, you guys see if you can figure it out. I know it's written there, but try to figure it out anyway. What should it do to that DCT reabsorption of sodium? Increase it or decrease? Decrease. That's what it does. If you release ANP, you say, I don't need any more sodium. My blood pressure is already too high. So what ANP does is it targets the distal convoluted tubule and says no more sodium reabsorption. Okay? And that will help to drop your blood pressure. Everybody okay with that? Yeah? So that corresponds exactly to what you already learned about ANP. It's just giving you a location and a specific mechanism. So ANP still does what you said it did, which is targets the kidney to inhibit water reabsorption or promote urine loss or whatever, targets the kidney to decrease the blood pressure. But now we have some details to fill in. It targets the distal convoluted tubule of the kidney to decrease regulated sodium reabsorption. Does that make sense? Okay, so in addition, it does two other things that should be consistent. Does it make sense to you that ANP also inhibits aldosterone release? Does that make sense to you? Yeah, that's logical, isn't it? Aldosterone you need when your blood pressure is too low, for instance. You don't need it when your blood pressure is too high. So whenever you release ANP, it keeps you from releasing aldosterone. And then it does one other thing that I hope you can put together. So you release it when your blood pressure is high and you've got prolonged atrial stretching and it goes there and it says no more sodium reabsorption, right? But in addition, it also causes dilation of the afferent arteriole, which doesn't affect reabsorption. What does it affect? Filtration. So how would that help? If you dilate the afferent arteriole, what will it do? No, it doesn't. Moves more sodium out. So it hits it twice, right? It says more sodium out, less sodium reabsorbed, right? So it's really effective about what it's actually doing. So it hits filtration and reabsorption. It hits both of them. And it also inhibits aldosterone release. So that's what ANP does. That's how it does its job. Good? Whoa! Graceful. Graceful. Okay. All right. So now we've got to get to aldosterone, right? Because we know that aldosterone is probably going to do the opposite of what ANP does, right? Because we know that aldosterone causes sodium reabsorption. And it didn't act at the proximal convoluted tubule because nothing does. So it's got to act at the distal convoluted tubule, right? So there are some stimuli that can cause an increase in the regulated DCT reabsorption of sodium. And they should make sense to you. So under what circumstances would I want to reabsorb that 35%? What if I had a decrease in blood volume? Yeah? What if I had a decrease in cardiac output? It doesn't have anything to do with the kidneys directly, but the kidneys are like, I don't know how to do anything with the heart, but I'll give you more volume, right? So what if I had a decrease in blood pressure or blood flow to the kidney? Any of those, right? Those are good triggers for increasing that 35% reabsorption. Also, one other thing, you can also look at the filtrate and see if it has too much sodium in it to see if you need to reabsorb some of it. Okay, so this is the story that we've already told, just adding a little bit more detail to it. So what happens is, again, our friend the juxtaglomerular apparatus, this time is actually going to release renin. So this is not going to be intrinsic, it's going to be extrinsic. So here's what happens. Remember that the afferent arteriole can respond to differing degrees of stretch. And it has low level of stretch. It might be an indication of low cardiac output or low blood volume or low blood pressure, right? Any of those things. If it detects those, you know what it does, right? It secretes renin. Renin converts angiotensinogen to angiotensin 1, right? Angiotensin 1 interacts with ACE from the lungs and ACE converts angiotensin 1 to angiotensin 2. And then how does this story come back to aldosterone? Because angiotensin 2 will cause the release of aldosterone from the kidney. And what does aldosterone do? So let's look at the DCT. So this is specifically the DCT, okay? So what's going to happen at the DCT is I have these tubule cells. And then I have the blood. This is the filtrate. And when aldosterone is present, it's going to impact this transporter protein that's on the surface. It's a carrier. And what it's going to do is aldosterone will cause sodium reabsorption. Up to 35% sodium reabsorption. But I want you to remember what you know about aldosterone. It doesn't move sodium by itself, does it? What does it move with sodium?
Water.
One of two things, not water. Positive ion. Yeah, it moves potassium out or H+. So basically, aldosterone is always going to cost you something. Okay? So let's put this back together. What I'm saying is, if you detect low pressure at the afferent arteriole, ultimately it's going to cause the release of aldosterone, which will cause sodium reabsorption and potassium or H+ secretion. Okay? And this is at the DCT. Okay? So, what do you think that ANP does to this picture? Yeah, it stops it. ANP makes sure that that doesn't happen. Aldosterone promotes it, and ANP inhibits it. Okay, ANP inhibits this 35% reabsorption. Okay, so that's happening at the distal convoluted tubule. So the net effect, guys, it increases the regulated DCT reabsorption of sodium, the net effect is to increase sodium ion and potentially water reabsorption, and that results in an increase in blood volume and a what in blood pressure? Increase. So it's the story that you already know. Again, you know that aldosterone increases blood pressure, but this is putting together the details, right? Okay, so angiotensin II, of course, also has another job, but we're not really concerned with what's happening at the vessels right now. Okay, so the opposite is also true. If you detected high blood pressure right there, it would inhibit all of this, right? Okay, so, but of course, when sodium is reabsorbed at the distal convoluted tubule, you lose potassium or H+, and that's going to be important in just a second. Because whenever you do sodium reabsorption at the DCT, it's going to cost you one of these. So you actually are doing secretion of one of those. So when we get to the secretion step, we'll come back to those. Okay, so that is sodium. Okay, your big thing to listen to or read for when you're talking about sodium is that please note that we have talked about moving sodium 3 times already, which means that knowing these words is going to be fundamental to you understanding what's being asked of you on the test. Because do you agree that I do both sodium filtration, yes, and sodium reabsorption? And then I do 2 different instances of sodium reabsorption. I do non-regulated sodium reabsorption at the PCT and then regulated sodium reabsorption at the DCT, okay? So can you see how important it is going to be to know 1, 2, 3, these 4 terms, right? Because if I ask you about sodium reabsorption and you tell me something about sodium filtration, you'll get the question wrong, okay? So the first thing that you need to do is to make sure you know exactly what's moving why in all of these 3 terms, all of those 4 terms. Okay, so the other ones are easy. The other reabsorption mechanisms are not hard. So now, the other reabsorption mechanisms, so potassium ion reabsorption, here's how potassium ion reabsorption occurs. It occurs at the PCT, and you are able to reabsorb a maximum of 90% of the potassium that you filter out. So you are losing potassium at your kidneys all the time. So you're able to reabsorb, and that's just because they hit saturation. Your potassium reabsorption hits saturation. So you reabsorb a maximum of 90% of the potassium at the PCT, and it's active transport, and you lose 10% at least of the rest. But please note, you can lose more than 10% if you have our friend aldosterone, can't you? So looking back at that table one more time, usually how much potassium do you get to retain? Only about between 80 and 90%, usually about 85 or up. Okay, so which one are you more likely to be deficient in, potassium or sodium? Potassium. You don't have a really strong regulatory mechanism for potassium. You're always going to lose some of it, so you always actually need to eat more potassium than you actually need in your body. Okay, so the negative ions, chloride and bicarbonate, you are moving so many positive ions back in via reabsorption that you're creating an electrical gradient. And since you create such a strong electrical gradient, you don't need to have to worry about moving these. They will just follow all of those positive ions in. So generally, chloride and bicarbonate ion reabsorption is passive and you don't really have to worry about it. Okay, last thing is water reabsorption. Water reabsorption generally follows sodium reabsorption. So I'm going to reabsorb it twice, right? I'm going to reabsorb it at the PCT and then potentially at the DCT, maybe if I need it. Okay. So water is going to passively follow all of that sodium. So basically what we're going to have is we're going to move massive amounts of solutes in, right, out of the tubule back into the capillaries. And as the solutes move, you create an osmotic gradient for water to move. So basically 65% of the water is going to get reabsorbed via non-regulated water reabsorption at the PCT. Corresponds to the 65% of sodium, okay? But what about the other 35%? The other 35% can move with sodium if a hormone is present. What hormone do you know that is related to water reabsorption? ADH, exactly. So this is where we put ADH into this story. So the reabsorption of the remaining 35% will follow, but the cells of the distal convoluted tubules, stick with me here for a second, The cells of the distal convoluted tubules have tight junctions between them and water doesn't move very readily, which means I have to transport it on purpose. And so I can control it when I'm transporting it on purpose. So what's going to happen is water will follow, but only if ADH is present. So this means that the distal convoluted tubule, is there ever an instance in which I would want to move sodium without water following it? Yeah, what if I was sodium deficient, but my blood pressure was fine, right? So you can couple sodium and water reabsorption, but you can also uncouple them, okay? So what is necessary for water reabsorption at the distal convoluted tubule is ADH, okay? Antidiuretic hormone, which I think you've heard of before. ADH comes from where? Posterior pituitary. So now let's just put this back together with being a human. So what happens is, when do you release ADH? Okay, if I have blood that is going by my posterior pituitary that is either low volume or really hypertonic, remember? Okay, then I can actually release ADH. And when I release ADH, it's going to cause DCT, regulated reabsorption of water, up to 35%. And then what's going to happen is I am going to pee very little, right? So what's going to happen here is if I detect hypertonic, low volume blood, I'm going to release ADH, I'm going to do a whole bunch of reabsorption, and I'm not going to pee very much. And ADH is also what causes you to be thirsty. So it causes the thirst response, which doesn't fix the problem instantaneously, but can fix it long term. That makes sense? Okay, so what if it's one of those times in which you decided you're going to be healthy and you're going to try to drink like 8-ounce glasses of water per day, which is so gross. It's so hard to do. Oh my God. Every time I do it, I'm like, I'm drowning. Okay, so if your blood is high volume and really hypotonic as it's going by your posterior pituitary, that's going to inhibit the release of ADH. And in the absence of ADH, regardless of what sodium is going to do, water's not going to follow it. So you're going to pee a lot, right? And it's going to inhibit your thirst response as well. Does that make sense? Okay, so remember that there was a disorder that you learned, which was diabetes insipidus, which was a lack of ADH, which made you pee like a racehorse. Okay, so the ADH release is controlled by basically the water concentration or osmolarity of the blood. So that's water reabsorption. So it's still 65-35, but the 35 only moves with ADH. Okay? And then last thing, what if something gets dumped out on the lawn and I don't have a transport mechanism for it and it's not lipid soluble? Well, then it stays out there, right? If I dumped it out there and there wasn't a mechanism for bringing it back, then it ends up staying out there. With the exception of lipid-soluble substances. They do whatever the hell they want. If you push them out via filtration, they'll just move right back in down their concentration gradient. So can you see why the kidneys are not very good at clearing lipid-soluble substances from your body? They're really hardly effective at all. They can't really do very much. It just diffuses straight back in. So if they have no carrier molecule or no way of reabsorbing them, then they get left out there. Okay, so that was the hard part, and now all we have to do is tubular secretion. So the last stage is tubular secretion. So when I'm doing tubular secretion, where does it occur? What's the anatomy? It goes primarily from the peritubular capillaries, right? We're going from the capillaries into primarily the DCT, although there's a few things that are exceptions to that. And so what I'm doing here is one last check through all the cabinets and under all the beds, because there might be some more cat poop in the damn house, in the hoarder house, right? Or there might be another 200 cans of corn in a cupboard that I didn't look in, right? And so I'm doing this time a selective look through the house to figure out what actually needs to go out, okay? This is your last time that you get to do it because the DCT is when you're almost done in the nephron. And so what I'm going to do is I'm going to get rid of some things that didn't move effectively or enough by filtration, like some nitrogenous waste like ammonia, some waste products from medicines like penicillin and phenobarbital, some urea and uric acid if I need to get rid of more of that. And then remember that I am going to excrete, or secrete, potassium and H plus whenever aldosterone is present, right? And it's going to happen at the DCT, right? Because this is where this happens. So at the same time as I'm reabsorbing sodium, I'm actually secreting potassium or H plus at the distal convoluted tubule. Okay, and then one last thing is that the kidneys have a phenomenal way of helping you to regulate your blood pH. In addition to doing this, they also have the ability to do this, and this is really cool. Inside these DCT cells, I have the ability to force this damn equation that you've seen 3,000 times by now. CO2 plus H2O yields H2CO3, which then dissociates H plus and HCO3 minus. So what can happen is the kidneys can help you take care of your blood pH by forcing this equation inside the cells and then deciding what to do with the H plus and the HCO3 minus. Okay, so I want you to imagine that the blood was slightly acidic, slightly low pH, and then I force this to occur. And then I decide what to do with the H plus and the HCO3 minus. If the blood was slightly acidic, what would I do with the H plus? I would leave it in the filtrate. What would I do with the HCO3 minus? I would put it back into the bloodstream to help with buffering. Does that make sense? So the kidneys can do this to help you with buffering your blood. Even if the pH problem was not a carbon dioxide problem, you've always got carbon dioxide in your blood that you can use to help fix the problem, right? So they force that equation and then they sort of decide what to do with the H plus. You can actively secrete it or actively, or do something with the HCO3 minus. Okay, so to summarize, here's a summary of what you're going to do. I don't need to summarize what's going to happen in the PCT because the PCT does whatever the hell it wants. Pretty much 65% sodium, 65% water, 90% of potassium, and if you can, 100% of glucose, right? Okay. And then what are you going to do in the DCT? Well, it depends on what hormones are present. In the DCT, let's assume that we have no A and P, but we do have aldosterone and ADH. And then what's going to happen in the distal convoluted tubule is sodium will be reabsorbed, and all of that positive will be followed with the negatives, chloride and HCO3 minus. And then the rest of the sodium that's moving in will be balanced by positives moving out, potassium and H plus. So the summary is this. At the DCT, if ADH and aldosterone are present, you are going to reabsorb sodium, chloride, HCO3 minus, and water. And you are going to secrete potassium and H plus. Good? That's the summary of the summary. And we're done with the hard part. Next time, all you have to do now is talk about why you pee so much.
I have a question.
Okay.
So naturally, because when I think of salt coming into the body to retain the salt, it should hold all the water. I would think, because it would trap the water to it, correct? So maybe I want to make sure I don't misunderstand this. So the water, when it's reabsorbed, it's only based on how much salt you have in the body, or how much?
It's not all that it's based on, because you can reabsorb it with ADH, and the salt is not always coupled to water reabsorption. So you can decouple it by taking out the ADH out of the equation. But typically speaking, if you take in more salt, you are going to retain more fluids. Yes. Because you are going to reabsorb more salt and therefore reabsorb more fluids is what's going to happen. So there is a correlation. It's just not quite as simple as people expect it to be, because there's also two hormones involved with the correlation.
So if I had high sodium and then I would probably not want to have, I would normally want to have a higher ADH so I can retain the water, correct?
No, you only want as much water as you want. You don't need a higher than normal blood volume. You need 4 to 5 liters. And then after that, you don't want any more because it'll increase your blood pressure. Below that, you do want more. So this is not released at a constant level. It's just tweaking based on, if I had coffee this morning, it's going to make me pee like a racehorse, right? And then I might need more ADH, right? So that is changed based on the body's needs. Okay, so the last thing is just to talk about how much you pee and why every day. So normally, everything that comes out here is excretion, right? So that is what you're going to pee ultimately. So what is it that changes how much you pee? Well, one of them is you generally pee anywhere from 1 liter to almost 2 liters per day. And it varies with your blood pressure. Does it make sense to you that generally higher blood pressure, more urine production? Yeah, because of the filtration. So higher blood pressure usually causes more urine production, which can make people be dehydrated even though they have a high blood pressure. And then if your blood pressure gets too low, you're going to start that whole renin business. Okay, but then the blood concentration is also impacted by what you drink, right? So I know that you paid for this class just for me to teach you the nugget of wisdom that if you drink more, you pee more, and if you drink less, you pee less. But I'm going to tell you that the reason we can actually put it together is this. So if you drink an excessive amount of water, then what happens is the water concentration of your blood increases. And then that is detected in the posterior pituitary, then inhibits the secretion of ADH. And then water reabsorption in the distal convoluted tubule doesn't happen even if sodium reabsorption does. So if you drink a lot, you pee a lot, but the missing link there is ADH, right? If you drink a lot, you inhibit ADH and therefore you pee a lot. Because it's not like the water goes straight to your urinary bladder, right? There's stuff that happens in there for sure, right? Okay, and then if you drink a lot, you pee a lot, but there's a reason. If you drink a lot, what happens, if you are dehydrated, you pee less. And the reason is the water concentration of your blood is hypertonic or highly concentrated. The water concentration of your blood is decreased and the solute concentration is higher. And when that is detected at the posterior pituitary, you secrete ADH. And then the ADH goes to your kidneys and causes the water to be reabsorbed at the distal convoluted tubule, which means that you are not going to pee very much, and whatever you pee is going to be stinky and highly concentrated because it still has all of that other stuff in it, just not very much water to dilute it. So, brilliant Melanie is going to tell you that if you don't drink very much, you don't pee very much. You're welcome. So a small volume, but it's ADH. It's all ADH. Okay, so and then the other things that cause some changes are temperature. So temperature can also change urine production, and it goes like this. When you're really hot, you start sweating and you start losing fluid via your skin, and when you lose fluid and also sodium via your skin, then what happens is you change the water and salt concentration of your blood. And when you do, you will actually inhibit sodium reabsorption and water reabsorption, because if you drop your sodium concentration of your blood and your water concentration of your blood, then you're going to change your ADH and aldosterone secretion. So if you sweat a lot, you don't pee a lot because you already lost the fluids. Okay, but then here's this one that if anybody camps besides me, this drives you crazy, because what is going to happen in the middle of the night when you're camping and it's freaking freezing outside? You are gonna have to pee without exception. You can't find your damn shoes, and there's like 3 kids on the way to the door of the tent is what's gonna happen. So there is a reason for this evil, evil truth, and it is this. When you are cold, you do peripheral vasoconstriction to keep the warm blood close to your core, right? So your hands and your feet would be cold if anything is cold. And when you do that, what happens to the blood pressure in your ventral body cavity? It goes up. And when you increase the blood pressure in your ventral body cavity, what happens to filtration? Yes, you do more filtration. So you actually make more urine at lower temperatures, which is rude. Totally rude. Because if you're a woman, you also know you're going to pee on your shoes in the dark, right? It's totally going to happen, right? It's going to happen. You're like trying to wedge yourself up against the tree and trying to go, I do not want to pee on my shoes. If I'm pissed off at my husband, I'll take his shoes. He'll never know. Okay. So the last thing is just to talk about how diuretics work. Just give me a couple minutes and it won't take long. Okay, so here diuretics work like this. You can either work on the 65% or you can work on the 35%. If you inhibit reabsorption at the 65% at the PCT, it's going to be a really effective diuretic, right? That makes sense? But the problem is that if you inhibit the 65% reabsorption, you're going to deliver all of that sodium to the distal convoluted tubule. When you deliver all of that sodium to the distal convoluted tubule, it's going to try its best to reabsorb as much as it can because you didn't do any of the 65%. It's going to try to do the whole 35%. And when it does that, you're going to be really effective at the diuretic effect because you're going to lose a lot of sodium, a lot of water, right? But then you're going to try to reabsorb all of it here at the expense of our friends H+ and potassium. So these are incredibly effective diuretics. They're usually given as an IV or a drip. One of them is hydrochlorothiazide or Lasix. The problem is that these cause a dangerous loss of potassium. Can you see why? They don't affect the DCT, but the DCT tries to make up for what they did. So they cause a dangerous loss of potassium. So usually you would be on a potassium drip simultaneous to whatever Lasix or whatever you had. That makes sense? And then the other one, there are some, by the way, those they don't usually give as a maintenance medication, like you can't go home with those kinds of diuretics. They're like too dangerous and effective. The ones that are less diuretic and you could actually be given a prescription for to take it home work on the 35% DCT, and all they do is inhibit this. So they're not as effective, right? They're not going to be able to, for instance, drop your blood volume as much and your blood pressure as much, but they're nowhere near as dangerous, right? Because they don't cause any loss of potassium. And so one of those is spironolactone. And then our friends that we might use on a regular basis, and I won't test you guys on the renal calculi stuff. Alcohol. Alcohol is a diuretic because it inhibits ADH secretion. So it actually causes problems right here, right? And that's why you pee a lot. Why is coffee a diuretic? Because we definitely know that it is, right? Coffee is a diuretic because it increases your blood pressure and therefore increases filtration. That's what it does. And the last one, what about those like water loss pills? I'm trying to remember the name of those that you can take over the counter for like PMS and water retention. You know what I'm talking about? Midol has it in there, and then there's other ones. Anyway, I can't remember. So there's these over-the-counter water loss pills which sometimes women take when they're PMSing and like really retaining water. They're kind of interesting because all they do is we know they'll get filtered out, but there's no reabsorption mechanism. So they're called osmotic diuretics because as they go through the tube and don't get reabsorbed, what do they do to water? Same thing that glucose does, right? And so you end up peeing a lot more with those. Not as effective as either of the other two, but safer. I mean, you're not supposed to take tons of them. People, bulimic girls have like killed themselves because of the loss of ions from using those things. So you're only supposed to use them every once in a while. Okay, I won't test you guys over renal calculi, which is just kidney stones, or any of the other stuff on here. I am going to either tomorrow or Saturday, no, either Friday or Saturday, post a short intro to the respiratory system so that you won't feel as overwhelmed on Monday when you come back. It's not new information. I mean, it's not extra information. It's just getting you guys started so you'll be a little more comfortable. So look for that. Yeah, I think I put respiratory before. It's not your fault.